right, I think we just go ahead and get started so that we can finish in time, so that everybody can go out to play, right? So for those who don't know me, my name is Zaibo Lee from the Ohio State University. I'm a breast pathologist, also doing cyto, but interested in digital pathology and AI in practice as well. All right, I understand this is the last section of the meeting. I really appreciate you are still here with me. All right, let's get started to I'm going to talk about some AI application tools focusing on breast pathology. How do we evaluate them and implement them in practice? So I have nothing to disclose related to this talk. I'm going to start with a couple slides with this year's Nobel Prize. As we know, the physics prize went to Dr. Hopfield and Dr. Hinton. Dr. Hinton is the father of AI, as we know. And also the chemistry prize went to three people who actually contributed to the computational protein design or use AI to predict protein architecture. So I believe it's an exciting time for us to be a pathologist and doing work in medicine, and I hope someday the Nobel Prize in physiology and medicine will go to someone who kind of related to AI or develop anything very useful in medicine or even in pathology. So, currently we have all these digital data, molecular data available in pathology, and we really need some AI algorithms to kind of use this data and become a useful tool for our clinical routine practice. All right, as we know, pathology is kind of, especially anatomic pathology. We look at the image, give a diagnosis, right? The digital pathology is kind of a tool to digitize those glass slides into digital file. Then the computational pathology just use those digital file and combined with computation power AI to, either help you with the diagnosis or predict some, response or genetic or alteration in your routine practice. Some of those tasks the AI can help with include diagnosis, for example, tumor detection, IHC, ISH grading, scoring, and morphological subtyping, and also prediction like genetic mutation, even genetic tumor burden, or biomarker quantification, or even truly prognosis of the patient and their outcomes. So just a very brief introduction about AI, machine learning. I'm not a computer scientist, I just very superficially brief through this. So AI basically aims to simulate human intelligence using machine and allow them to perform tasks such as learning, problem solving, and decision making, just like a human. Machine learning is just a small branch of AI that programs computer to optimize the performance criteria using those data and even previous experience. Multimodal AI, is kind of AI tool to use multi data modality such as imaging, such as text, or even other data format. So machine learning can learn data pattern present from training data, input data, and then match new case or new data to previously identified pattern. This training format can be supervised, unsupervised, or mixed, so-called semi-supervised. The output categories, in the machine learning model can be a regression model, can be classification model, can be class tree model. So there are so many there. We are not going into the detail. And deep learning, just a subset of machine learning using CNN, convolutional neural network, to learn data to predict the future data. More and more new models are emerging, including generative AI. These are the models specialized in generating new data, similar to the training data, such as ChatGPT, GPT-4, and others. Foundation models are an emerging class of AI models trained on vast quantity of unannotated data, just enormous data, trained on those to predict, to be useful in the future prediction. Transformers are neural networks that use a self-attention mechanism to capture relations among those data. So this diagram shows the evolution of machine learning models. Before, in 19th century, such as support, vector machine, random forest, those are basic machine learning models up to the current, graph neural network, even transformers here. Before we can even use or develop these AI tools, especially specifically in pathology, we need the digitization of our slides or our material. So we need the digital pathology implementation, and we need this workflow in order to use these AI tools. So in this workflow, you need to scan those slides, put them, in your IMS, image managing system. Then you can implement the AI tools to help you with diagnosis or other tasks. As we know, it has been very successful in the digital pathology development. The FDA has approved so far 3 systems, including Philips, Leica, and Hamamatsu for the past 7 years. And CEP has also published 2 versions regarding the recommendation guidelines how to validate, implement the whole slides imaging system in your clinical practice. And the details are in this table, including how many cases you need to validate each scanner, each system, and how much the concordance should be between the glass and digital arrays. Those guidelines are for surgical pathology. In the cytopathology area at ASC, we have published these guidelines last year, how to evaluate and implement digital cytology in your clinical practice. These are the recommendations. I'm not going to the detail, but those are very similar to the surgical pathology recommendation. But as you know, cytology kind of have much more specimen type, staining techniques. You need to validate each of those combinations separately. So as the digital pathology system mature, and then the AI system also starting to emerge and mature. So it's it's exciting time to be a pathologist and work in the pathology area with this digitization and enormous material. Currently, as we know, we have this abundance of data in pathology in this area, and again, the technology is just advanced to have all these cost-effective, high-performance computing power, those GPUs. So those technologies are available. So right now, we just need better algorithms. We need these algorithms to be able to help us in our routine clinical practice. And how this AI can help a pathologist? I separated them into 3 stages: before sign-out, during sign-out, and post-sign-out. So before sign-out, this AI can help us to screen, cases. For example, in cytology, screen pap smear, urine cytology, or even some surgical pathology, prostate biopsy, breast biopsy, help us screen them whether there are any abnormal lesions there. During sign-out, they can do real-time digital assistance, like just digital fellow, highlight those areas you need to review during sign-out, and also can automate the reporting of your case, right? You don't need to dictate, you don't need to type in those reports, you just, let the AI run the report. Post sign-out, hopefully the AI can help you QA your report, QA your department. You don't need to do this manually anymore. So those are the potential usage of AI during our routine practice. And this slide lists some current challenges in our practice today, such as lack of standardization. Right now we are still doing subjective diagnosis, right? It's kind of a manual. Some experts have this diagnosis. They don't agree with your diagnosis. But then many manual process like counting mitosis, quantify those biomarkers, and also again shortage of pathologists. We have to work a long time. So hopefully in the future the AI can help us to relieve these challenges, such as standardize all these process. Very objective diagnosis. We don't need to rely on experts' opinion anymore, right? But before we can use any AI, we need to ask some questions. So does this AI tool work? Are we there yet to use these AI tools? And does it make pathologists more accurate, means in diagnosis? Or does it make pathologists faster? So if it's just a kind of add-on step process, cost you more time, nobody wants to use that, right? Then does it save us money? So we will go through these questions later on using the real examples. So this table summarizes some of those commercially available pathology AI products. Some of them have received FDA approval, such as the Terra AI for prostate predictive test, hologic Genius system for pap smear screening, and Page AI prostate AI to screen prostate biopsy. This table focuses on the breast pathology, since today we are going to focus on breast pathology. Summarizing the current commercially available breast pathology AI products, highlight the IBEX one currently is under FDA breakthrough device, and below the Page AI for breast cancer lymph node metastasis, also under the FDA breakthrough status. The CEP, together with the other society, including DPA, published this recommendation, I think early this year. It's available now for a performance evaluation of machine learning AI in pathology. They put out some performance-specific metrics, how to evaluate the AI tools before you can use them clinically. And at ASC for cytology, we also publish a recommendation, not recommendations, kind of a consideration before you can implement or validate those AI tools for your clinical practice. Not go through those. So this timeline is for our institution at Ohio State University. So starting in 2017, since the first digital pathology system received FDA approval, the Philips system, we start to implement digital pathology for our routine practice. And by this process, first it's very slow because of the pathologist resistance, but during pandemic, this process has just promoted rapidly. Every pathologist wanted to use digital pathology so that they can sign out at home and did not go to their office anymore. And currently, we are evaluating and validating, implementing AI tools during our practice. Some of those AI algorithms or tools are listed here. We are currently evaluating and validating them, and I will give you some of those examples later on. So personally, I categorize those tools into 4 categories: detection, classification, quantification, and prediction. For detection, There are lymph node metastasis detection, cervical cytology, abnormality detection, or screening, urine cytology, abnormality detection are some of those examples. Classification, basically, those tools can help you classify the lesion, whether, what kind of lesion, whether it's benign, malignant, or very specific, like atypical lobular hyperplasia in breast pathology, or prostate adenocarcinoma in prostate biopsy. Then quantification, mostly for biomarker, but you can also use some of those tools to do the tumor grading, to count mitosis, and any other which need a quantification. Prediction can be used to predict response to therapy, whether it's chemotherapy, immunotherapy, or radiation therapy. Then you can use those tools to predict specific genetic alteration, such as MSI, BRCA1 mutation, or any others. Then you can also predict the risk or long-term risk recurrence, especially for breast or prostate carcinoma. So we all know the Oncotype DX SE, which is a molecular test. It's a pretty costly test. Someday, if you can just use the glass slides to predict the patient's recurrence score, so you don't need to run those expensive molecular tests anymore. So let's start with this lymph node metastasis detection. In our institution, we use AI tools to screen those lymph nodes. We summarize our results and publish the validation result, I think, last year. I will go through this process. So this is our IMS, image managing system. When you open a case, it automatically brings you to the specific slides in the IMS. In the IMS, you can just click on the left, you can see the case metadata. This is a very small file, just a slides information. So you can just click that and open the file into the AI platform, so-called VisioFarm. So in this AI platform, the whole slides image will be streamed here. So not, downloading, uploading, just streaming. So you don't. It's a very fast process, no delay at all. In this AI platform, then you can select a run analysis. The process involves multiple AI algorithms here. You can select them all at once, or you can select one by one. I just want to show you the steps so that I can, later on, I have a video to show you step by step. But right now, just show you the result. As we can see here, the AI tools highlights the potential tumor metastasis in the lymph node, so that you can just focus on those highlighted area. You don't need to look at other area, just than those highlighted area. So give you some real example. This is a lymph node with a micromass. You see the AI tools annotate those potential metastases. Different color means a different probability. The red one means a highest probability to be a metastatic tumor. Then, as you can see here, let me see. Okay, this is high power already. Those are really AI tools can identify those small foci of metastasis. Here is another example of a lymph node from a breast cancer patient. Believe this patient received neoadjuvant chemotherapy. On the right, you can see those therapy-related change. Then the AI tool highlighted this very small focus of kind of abnormal cells. This is focus of isolated tumor cells. So these tools can really help you to identify those. Here are examples from patients with invasive lobular carcinoma. The AI tools help you to annotate the area of metastasis at low power in panel A. B, you see exact the border of those metastatic tumor annotated by the tool, AI tool. C and D as well. In summary, these AI tools had a sensitivity of 100%, which means it did not miss any single real positive metastasis. However, as you can see here, the specificity is pretty low, lower than 50%, similar for the PPV, positive predictable value here. Some of those false positive causes include histiocytes, crushed material, germinal center, as shown here, even blood vessel, or contaminated epithelial cells there. And we summarize the most common false positive cause is histiocytes, as shown here. But when you have those annotated image, it's very easy and fast. Just quickly review those. You just slim through those images pretty fast. And actually, we do not have the data here. Significantly reduce the time to review those lymph nodes using the AI annotated images. Oh, here is please to run this. It's running. Yeah, here we go. Okay, here is a step-by-step video. As you can see here, I select the slides in IMS. Now it's streaming into the AI platform now. So in the AI platform, you can select all these algorithms at once or just one by one. Right now, I'm selecting the first one. It's a tissue detection. It's automatically detect the tissue to be run with the lymph node metastasis algorithm. So next one, right now, it's running the metastasis detection. However, this process takes time, usually like a couple minutes or 3 minutes for a slide like this. You can do this in batch. That means if you have a resection specimen like 10, 20 lymph node slides, you can batch them, put them in the AI platform, then run the batch analysis. At the same time, so you can look at the breast tissue slides, give the tumor size, the tumor grade. After you are done with the breast tissue slides, then you can go back this annotated image as shown here, those small foci of metastasis, then you just summarize, quickly review them, summarize the result as shown here. So right now, I think the process here is to select multiple slides, run the batch analysis. You can do this before your sign out. And during sign out, you just need to review those annotated images. All right, I think I just move to next slide. So next category is classification. I will give you an example using IBEX Gilling system. This system was developed based on fully supervised multiple layer CNN network designed to classify, analyze the real world WSI, trained on 2 million, more than 2 million labeled images. And the development of this AI tool was published, I think, 2022 with very high AUC. I think it's 0.99 for invasive ductal invasive carcinoma and 0.98 for DCIS. So the validation process during the development was based on 385 cases and 8 breast pathologists. During the validation, they separate this into either major discrepancy or minor. As you can see here, if it's a benign versus invasive or DCIS, that's a major discrepancy. Some minor discrepancies include whether there is a microinvasion or just the DCIS grading difference there. As you can see on the right, for the microscopic arm, there were about 4% of a major discrepancy, but by using AI alone, without any pathologist review, there were only 3% major discrepancy. Then if you have the pathologist to look at the AI annotated image that's shown here, the final result actually achieved 100% for every single matrix here: sensitivity, specificity, PPV, and NPV. Here is an example of a very small, I don't know how small it is. It could be a microinvasive carcinoma here, missed by the pathologist using a microscope, but identified by the AI algorithm as a highlight here in red in this annotated image shown here. This algorithm can help you identify invasive ductal carcinoma, highlighted in this red color, also DCIS using the blue color here. During our validation, we found this algorithm identify all those invasive carcinoma except one single microinvasive carcinoma. However, when we look at this specific microinvasive carcinoma shown here in the middle panel, actually it highlighted the area but just with a low probability. So during the pathologist review, actually this was identified as microinvasive carcinoma. This algorithm can also classify whether it's lobular or ductal. If you select the, here, the invasive lobular carcinoma, it will highlight the potential lobular differentiation or invasive lobular carcinoma here in red. And it can also identify the lobular neoplasia as highlighted here on the HE. You see the morphology that's pretty typical for ALH, right? Atypical lobular hyperplasia. During our validation, we found one case was missed by the AI algorithm based on at least moderate or high probability. But when we look at this case, it's down here. It was highlighted by AI algorithm just with a low probability. That's the blue color. So during pathologist review, this ALH, very small ALH, was identified as well. So not only those abnormal lesions, this algorithm can also help to identify microcalcification. As we know, many breast biopsies, if you are a pathologist, you need to identify those calcifications, right? For many breast biopsies identified, on imaging, those abnormal calcifications. Sometimes, it can be very time-consuming, and sometimes you may need to get multiple levels, right, of the section in order to identify those small calcifications. And these AI algorithms can help you to identify those small calcifications, as shown here. If you select the microcalcification, as shown here, this one can, as a highlight here in red, can highlight the microcalcification. If we look at the HE, you see how small those calcifications are. This can help you identify this microcalcification and save you lots of time, especially for those small ones. Some big, large ones, pretty easy to look at and find them, but for those small ones, it can be very challenging and time-consuming. So during our validation, I think one microcalcification was missed by the algorithm shown here in this lower panel. Actually, this is calcification caused by the calcium oxalate. If you do breast pathology, these are the challenging ones, because they are not purple color not dense than. These are just sometimes transparent. You only recognize those crystallized, calcification if you pay attention. So I believe the AI algorithm, was trained based on the data which probably did not contain this kind of a calcification. So they probably need to optimize their algorithm, using data containing this kind of a calcification in order to identify this. So we also compare the time spent, between non-AI and AI arms, and we ask 3 pathologists to look at. I believe this. There are 100 cases. We did the analysis. The AI tools did reduce the time spent by the AI. Assistant tools here. Additionally, using the AI tools, the pathologists request less IHC as well, especially for those lobular neoplasia. They did not request the IHC. There was, I think, it's about 30% of reduction of IHC ordering using AI tool. This is probably a significant reduction for money saving as well. So here, showed both time saving and money saving using AI tool. So the third category for the AI tools is quantification. I list some of those potential uses here, mostly biomarker quantification in breast, as we know here, HER2, Ki67, mitosis as well, and also grading, Nottingham grading. There are AI tools available for those Nottingham grading as well. There are guidelines available for the digital imaging analysis for quantification of, but these guidelines are only for HER2. So this was published a while ago, I think it's 2018, in this guideline. If it's a FDA-approved test or system, you only need 20 positive and 20 negative cases for your validation, and 90% for the HER2 positive sample, 95% for HER2 negative sample. But if the system is not FDA-approved system, you probably need double the cases for your validation, 40 cases for positive and 40 cases for negative. So this was from CAP. At DPA, we also published a white paper for some kind of a recommendation in quantitative imaging analysis for biomarkers, not only limited to HER2. You can apply these consideration or recommendations for any tissue biomarkers using quantitative imaging analysis. I will give you some example of biomarkers in breast pathology. The first one is HER2. I think there are lots of literatures there. We did several studies, including validation and also some prediction using the quantified result to predict the response to anti-HER2 therapy as well. So in this process, similar to the lymph node metastasis, we use the same AI platform. First of all, we open the HER2 IHC slice and open the WSI in the AI platform with your farm, as shown here. Then you can select the algorithms to run the analysis. The first algorithm is to identify the tissue sample to be analyzed. As shown here, the red circle highlights those controls, either negative control, equivocal control, positive control. Exclude them from analysis. Otherwise, every single case here will be positive, right, for HER2. Then only the green color shown here will be analyzed by the algorithm. So this is the algorithm available in the platform. You just need to select that, run it. it's an automatic process. So after running the HER2 analysis process, the algorithm will give you the final result as shown here in a quantitative number shown here, connectivity, and also a score, either 1, 2 plus, or 3 plus, or 0 shown here. During our validation, we found a concordance between HER2 digital imaging analysis score and pathology score at 87%. Well, because there are 3 categories here, right? Negative, equivocal, positive. Some of those equivocals were identified as negative by the digital imaging analysis. At final result, as shown here, all discordant cases were only 1 step discordant. That means the equivocal to negative or to positive. There was no negative one to positive, or the other way around, positive one to negative one. Just so 1 step discordant. There are some pitfalls using the digital imaging analysis tool for HER2 IHC quantification. Some of those air bubbles, as shown here, was categorized as positive, and similarly for the pigments, and some of those DCIS area could not be recognized. Was recognized as invasive as well. So the AI algorithm analyzed those area and give you false positive result. And the ink as well on the resection specimen can give you false positive result. If you have WSI out of focus, even the staining is strong, complete, the AI algorithm was not able to give you a real positive result. So you have to, make sure the quality of your image, which are appropriate for digital imaging analysis before you do the imaging analysis. And then if we also found a case which had a very small cluster. This is from a neoadjuvant chemotherapy case. Just a very small cluster of tumor cells there. So the tumor detection algorithm there did not recognize this as invasive carcinoma. So classify this as a negative, but it's a false negative. Actually, it's a real positive case. So just to be aware, so the AI tool there's, but you still need the pathologist review after analysis. Some of those challenges are summarized here. Similarly, you can use AI tools to quantify ERPR and KICT7. Here is an example of quantification of ER, IHC, similar process, but there are many other tools or algorithms out there. I just use this as an example, to run the ER imaging analysis here. This can give you, the final positive, negative result, and also give you a definitive percentage, like how many positively stained tumor cells there as well. Even give you the number of tumor cells, how many, like thousands tumor cells with staining, and total tumor cells as well. So the final validation concordance was about 94%. That's pretty good, very close to the 95 concordance rate. Some of the pitfalls or challenges during the validation process is shown here. The first panel showed 1 false positive case with intermixed benign glands. This is a triple negative breast carcinoma, but because it's pretty small, but those are small glands, as you can see here, showed ER staining, and the algorithm did not exclude them from the analysis, so give you a false positive result. So that means you have to review these final results, before you can use them. The second one, I think it's a false positive case due to a tissue folding, as shown here. So the folded tissue had some non-specific staining of ER, so give you some false positive result. The third one, again, DCIS, invasive carcinoma. This is a kind of a challenge for the algorithm to recognize and differentiate in situ tumor from invasive tumor. So the last one, I think, is a false negative case due to a weak nuclear staining. But this one, after we adjust the threshold, actually, you can still recognize the positive staining there. So in this AI platform, you can further optimize the algorithm using your own slides or your own data. There is a process called algorithm optimization. You can, upload your own slides, then optimize this algorithm, then finalize the algorithm specifically for your lab to do a more accurate analysis. As mentioned, there are tools available to quantify the breast cancer grading scores as well. As we know, the Nottingham grading system, publication out there, and also the tools are out there. I just want to mention that. And also this is a publication regarding quantify the breast cancer grading scores as well. All right, let's move to the last category, prediction category. So in these categories, you can use the AI tools to predict response to therapy, including chemotherapy, radiation therapy, or immunotherapy, or predict genetic alterations such as MSI, BRCA mutation, and some other genetic mutation, even HER2 amplification as well. There are algorithms out there, although most of them are still in the research phase, not really in the clinical practice yet. And then there are tools available to predict to stratify the risk of a recurrence, similar to the Oncotype DX, in the ER positive, HER2 negative, early stage breast cancer patient, to stratify them whether they need a chemotherapy or not, similar to the Oncotype DX. I want to give you this example. We did a research on. We developed an AI model to predict response to neoadjuvant chemotherapy in breast cancer patient, triple negative breast cancer patient, and HER2 positive breast cancer patient. So in this study, we not only used AT slides, we also used the so-called multiplex immune checkpoint immunohistochemical stain slides using those three markers, including PD-L1, CD163, and CD8. As we know, PD-L1, we all know, CD163 is a marker for macrophage, CD8 is a marker for cytotoxic T cells. Lots of literatures out there suggesting the staining, not the staining, the presence of these cells can be related to the response to therapy. So that's why we choose these three. Some representative images shown here. The PD-L1 is the brown color, as shown here, staining, and the red color is a CD163, highlighting those macrophages infiltrating around the tumor or within the tumor area. Then the green color is the CD8, highlighting those cytotoxic T cells around. This is a peritumoral area and also intratumoral area. So we extract the image features from both HE slides shown here and also the multi-IHC stain slides as shown here. There are forgot how many, it's 32 image features we extracted from both HE and IHC stain slides, including stromal area, tumor area, and lymphocyte-rich area, and then quantify them, and also quantify those biomarkers in each area, and use this data to train models to predict response to chemotherapy in both HER2-positive and triple-negative breast cancer patients who received neoadjuvant chemotherapy. As we can see here, for the HER2-positive cohort, the model showed a very nice AUC, the area under a curve, very close to 0.9. However, it's less optimal or less significant for the triple-negative cohort. The AUC was only 0.77 here, but still good, okay? So this is one example to develop AI tools to predict response in breast cancer patient. Some other studies out there developed AI tools to predict survival, to predict response as well, and also mentioned here in this study to simulate or predict the oncotype DX score or McGee equation score as shown here. And also study out there use the AI tools to predict BRCA mutation as well, and I believe lots of them there to predict other genetic mutations in other tumor type, such as colon cancer, for MSI, endometrial cancer, some of those specific mutation, not only limited in the breast pathology area. So back to this table, there are two commercially available AI algorithms or tools. As highlighted here, one is from Alcuin, the other one from StratiPath. They both have similar AI models to predict the so-called relapse risk or kind of a risk of recurrence, just like the oncotype DX, to predict the recurrence risk and evaluate the patients whether they need chemotherapy or not after surgery. These are targeting ER-positive, HER2-negative breast cancer patients, and hopefully they can help or at least reduce the ordering of oncotype DX and reduce the cost for the patient. They are out there. They received this Europe mark, but not received FDA approval here at US yet. So I hope this talk can help or at least convince some of you the AI tools are here to help us as a pathologist to reduce some errors, make us more efficient, reducing the time spent either screening lymph node metastases or counting those mitosis, and also give a kind of accurate result in quantification of biomarkers or even diagnosis there, give you kind of objective result, avoiding some of those huge inter-observer variability there. So that's okay, last slide. So this is my last slide. Some references, during last several years from our group publishing in the digital pathology and AI in pathology, summarized here. And this concludes my talk. And thank you again for your attention. And yeah, any questions? Thank you. Any questions? Yes.
What's the workflow you adopt in your lab when you are doing AI with diagnostic?
So as mentioned, first of all, I think, okay, you probably need a digital pathology workflow first. So you have all those digitized slides available at your finger click, right? So the digital pathology system, when you select, I hope you can select an open system so that it will be much easier for you to integrate the third-party AI tool in there. We are having some challenges because we are using Philips IMS. It's a kind of a closed system. It's not easy to integrate the third-party tools there. So we kind of, using this streaming function, stream those digital images into another platform, as I showed you here. Yeah. So it's still pretty fast, but it's an added step. So, yes.
Yeah, just a comment. We have the Philips system, and we're running into the same issues. One avenue we've discovered is that if you find an IMS, we're not using the Philips IMS, so if you find another IMS
Yeah.
viewer or management system that's open source and can accept the Philips syntax files, which they're proprietary at the moment. Other scanners are, the file transfer from other scanners are actually easier, I think, in terms of some systems. But once you're in one of those platforms, then the AI tools can be either made by that viewer platform or not even on other companies. So the number of platforms, viewers and IMS systems that are open source to AI tools.
Exactly.
It's all
Yeah.
changing very rapidly.
Yeah.
But,
So.
that's the recommendation I would make, is that if you're going to start the system, is carefully select what scanners you want to use. It doesn't have to be the same scanner all the time, but with your the IMS and management system and AI tools. And as you've discovered, I'm sure, working with your IT people at the very beginning of this and implementation and planning is critical.
Yeah, exactly. Yeah. So during our implementation at that time back in 2017, that's the only system received FDA approval. We had no other choice. So yeah. So right now you have more options. So.
Right. Yeah, our health system decided they wanted the FDA, one of the two FDA approved systems, and the other one was older, so
Yeah.
Philips was the more robust FDA platform at that time.
Yes.
One more question. You mentioned if you needed to train the system, you upload your slide. Are there more efficient ways of doing that? Like, let's say you're looking at AI-67 or HER2 and you see a mistake that the AI has done. Can you train it by marking the slide? Or what are the mechanisms?
So you are not train them, from the beginning. Basically, you are optimizing the algorithm already there in the platform using your own slides, so that can lower the detection threshold or those kind of things. Yeah. It's right there. You can consult with the vendor. They will help you if you don't know how to do it. Yeah.
So the system is actively learning as you're changing the threshold.
Yes. Yes, sir.
Have you tried anything for
For HER2 low. Yes. So we submitted a couple abstracts to US CAP as well, not only HER2 low, also including HER2 ultra low. If you know the Breast Destiny clinical trial 06, those ultra low patient can benefit from ADC as well. So not in this AI algorithm I mentioned in my talk, but from the other vendor. I did find the variation among algorithms and even among the WSIs scanned by different scanners. From same glass slides, different scanners scan those WSIs, have a different ultimate results after the digital analysis. So, yeah. to answer your question specifically, the HER2 low, the algorithm we are using can classify all those tumor cells with staining, whether it's a weak, incomplete, or complete moderate. They separate into different category and give you exact percentage for each category. Then at the end, can summarize, classify them into different HER2 status. Yeah.
So instead of doing, if you do 2D imaging, it only takes one section. If you do 3D,
Mm-hmm.
you should be able to make something HER2 low to an ultra low to low or low to something, because you're only capturing one section. Are you trying to do anything, trying to do a 3D and then see if you can catch all the expression of the cell?
I do not have experience in evaluating those 3D. You are talking about spatial, like biology, or I know there are those immunofluorescence labeled or stain slides in 3D in real time. I do not have any experience, but I believe it's probably the future. You can evaluate spatially, not only on one cut level.
Yesterday
Yeah.
I talked to the Hamamoto.
Mm-hmm.
Hamamoto, they said they scanned it into 3D and I can see too. So I'm not very sure.
I think that's probably a different story here. So Hamamatsu does have a de-stacking scanning function. Some other scanners have those as well. From my experience, we are using those de-stacking function to scan cytology slides. Those have like a 3D architectural cluster of cells, not really for the biomarker quantification yet. So for most of surgical pathology, those I think a one-layer scanning is pretty good. It's enough, for routine diagnostic or quantification, Mm-hmm. Yes, sir.
About 20 years ago, I was head of a group of pathologists, We were doing breast biomarkers. The agreement among pathologists, reading the manual, was very poor, especially when it was used. These are experienced pathologists, thousands of cases under their belts. Just very difficult getting agreement. I adopted an early AI system, it's actually the first one on the market, and the problem just disappeared. It went away. The results, the clinicians and patients were so pleased, they did a story about us on evening news.
Uh-huh. It's nice to hear that. Yeah, exactly. Especially mentioned for the HER2 low, ultra low, the interorbital variability. It's about, even for the experienced pathologists, subspecialized pathologists, we did a study, with a huge interorbital variability, among those pathologists. Definitely the AI digital imaging analysis can give you more objective result. Yeah. Thanks. Okay, if no other question, I'm going to end this talk, and thank you again for your attention.